I mean, a 5.8% means she's been elevated for a while. You don't want to call it normal if it's 5.8. Hers probably ought to be 4.8.
So that brings the obvious question. What does that tell you about our patient?
She probably has diabetes, and if she doesn't have diabetes, she's going to get there very soon.
And maybe the real answer is it doesn't make a lot of difference whether she's a diabetic or not diabetic. The pre-diabetic state, that family history with diabetes, hypertension, that is a big iceberg below the water. And as that iceberg gets above the water, we call it diabetes. But when it's below the water, it's a huge cardiovascular risk.
Well, I'll tell you what the doctor tells Dolores. She says, you're on your way to having type 2 diabetes. And again, just nail it. What in this history, just point by point, would have led the doctor to tell her that?
Her hunger, her increased urination, her thirst, her borderline fasting blood glucose, her elevated hemoglobin A1C, her obesity, her hypertension. I should have asked,
what doesn't fit this pattern?
The family history,
we've gone
for
this
sure.
Far. We haven't really gotten a definition of diabetes. We know there's type 1, type 2. Somebody want to give me a bullet for each of these?
Type 1 diabetes, Peter, is an autoimmune disease where your beta cells that produce insulin become destroyed. You can be skinny, you can be fat. It really has nothing more than you just lose beta cells, you lose insulin-producing cells. Type 2 diabetes is really characterized by resistance to the action of insulin.
Laura, when you're sitting in the doctor's office, you've gone there in a panic.
Absolutely. I left work and went to the doctor's office.
You did. Were you worried about diabetes?
Yes. I was worried about everything.
So let me ask the docs this. If you're saying not seeing your doctor, not exercising contributes to the development of type 2 diabetes, are you blaming Dolores? Or is the old blame the patient game? You got diabetes because you didn't do what we told you.
Well, I think we have to recognize that part of what we're seeing in this country is the result of the obesogenic environment we now have created. Fast foods are prevalent. The availability of healthy foods, although very easily obtained in some neighborhoods, are very difficult to obtain in other neighborhoods. They're more expensive. We have ways of not exercising anymore. We've eliminated things in our schools.
Let me interrupt you. I think I'm hearing a yes. I think I'm hearing that.
No.
She lives in a toxic environment.
Yeah, that's exactly right. She lives in a toxic environment. She has some control over her environment, but until we really recognize that we have to not only look at what individuals are doing, but what the environment that they're living in is doing, until we tackle both, we're going to continue to have these problems.
The answer to your question is no, we should not blame her. That's not even the issue. The issue is you have this problem. What can we do to help you overcome it?
So the answer you're giving me is it doesn't matter. Let's fix it.
That's right.
All right. Let me tell you a bit more about Dolores. She's African American. In point of fact, does that make a difference in her diabetes risk?
This is a complicated issue. The easy answer is yes, minorities, particularly Native Americans, particularly Latinos, particularly African Americans, have a greater incidence of all these issues. When you drill down a little deeper, however, you discover some other things that were kind of surprising. For example, where you live geographically. An African American who lives in the South is going to have far more problems than an African American who lives on the West Coast. An African American, or a Caucasian for that matter, who lives in the South and is living in poverty actually experiences the same incidence of all these problems as the general population in the South. So it appears to not only be racially determined, culturally determined, genetically determined, but also your socioeconomic status or your poverty rate. And all of these things are interrelated.
Now, Laura, what did your doctor tell you to do?
My doctor told me to go home, and this was after a lot of blood work had come back. I got a phone call, and it was actually a nurse, and said, here's your results. We want you to eat low fat. We want you to change your, just switch to whole grains, and we'll see you back in a few months. And let's see if we'll take the same blood test again. So I said, okay, I can do that. Surely I can do that. Hang up and, you know, and trying to manage your way through that maze. I said, I have no idea what that means.
Dolores' doctor says pretty much what you heard.
Right.
I want you to lose weight.
Right.
Go do it.
Right.
In addition, her doctor wanted her to start taking metformin. What's that?
Metformin is a drug that is used to lower glucose levels.
It's a diabetes drug.
It's a diabetes drug. And now when someone is diagnosed with diabetes, instead of diet and exercise and diet, it's diet and exercise plus metformin. But no question, as Laura has seen, the exercise and diet is the most important.
Right. Well, there was a short discussion about medication, and I asked, do I need to go on medication? And the quick response was, let's try to control this through diet, which I was happy in hearing you say that. I wouldn't have wanted to mask what I was already doing, eating poorly, with a medication. The
problem with what we're discussing here is that we as a medical profession tend to treat obesity and diabetes as if it were a strep throat.
Right.
Here's the test result.
Exactly.
Let's write a prescription.
And you're done.
Patient's going to take the prescription and everybody's happy. Where we need to really approach these problems as a chronic disease, which is what they are. So the proper way to manage this would have been to see a nutritionist, to see somebody that will interview you to see where you are in your willingness to change your behavior, change your diet, look at the entire family, because you can't go into a household and eat healthy food and everybody around you is continuing to participate in this toxic environment.
Well, let me walk you through a few of these things, if I might. Metformin's a diabetes drug.
Right.
Is her doctor basically saying to her, to Dolores, you've got diabetes, have metformin? Or is her doctor saying, take metformin so you don't get diabetes?
There was a study that looked at a group of people that, like Dolores, were on the diabetes expressway going to get there, or were likely to get there, and some of them were given just metformin, and others were put on a very rigorous program to change their diet, impose exercise, and see if they could get them to lose some weight and control it that way. And the people who did best, who had the lowest risk of developing diabetes, were the people who lost weight through diet and exercise. Metformin also worked in terms of preventing or postponing and the development of diabetes for many of these.
So this is an insulin issue. Either she doesn't have enough or she's resistant to what she's got. Why give metformin? Just give her insulin. Why not?
Well, insulin in and of itself is not safe to just give to everybody, and you can run the risk of hypoglycemia, or very low blood sugar, which is more dangerous than having an elevated blood sugar.
What are the effects of diabetes we're trying to prevent here? Just lay it out for us just once, somebody.
Blindness.
Well, numero uno is cardiovascular disease. But
Heart
Lisa,
attack,
you're right.
stroke,
You ask
blindness,
patients
kidney failure,
what
amputations.
complication of diabetes they're most likely to get.
Going blind.
They say blindness.
So blindness is one, cardiovascular disease, what else?
Well, blindness
Kidney
is
failure
way
is
down.
another one.
But the biggest is
Amputations.
cardiovascular.
Bad stuff. Let me tell you what Dolores is told. Dolores and her doctor speak together, and they discuss the benefits and the risks of the metformin in specific. And together, they decide that she's going to start taking metformin. What do you think the outcome is going to be?
She's going to have diarrhea. She's going to stop taking it, and she doesn't change her diet. She'll be back.
You are a professional cynic.
I certainly am. I see a lot of diabetics.
Do you all agree?
Well, I think it's so easy for doctors to pull the trigger on a and feel like it's penicillin. We're done. But it's not like that at all. It's really an ongoing issue.
Give me a number. How many type 2 diabetics are there in this country? Do we know this number?
Yeah, about 25 million.
25 million.
And about a third don't know it.
Let me tell you a parallel statistic that is disturbing. 80% of type 2 diabetics in this country are obese. The problem I have with giving them metformin without all the other stuff is that we're treating their blood sugar, and we're not treating all the consequences of obesity.
All right, let's just pause for a minute. I want to sum up what we've been discussing, and then we'll pick it up from there, shall we? Type 2 diabetes, a huge problem in the United States, and the numbers are rising. It is a dangerous disease, and people at risk need about Dolores. Dolores starts her metformin. 3 months later, she's still on it. Her A1C, her glycosylated hemoglobin, has gone from